السلام عليكم. في الكيس حقت الاسوفاجيال برفوريشن اي في ناس يقولون انه put chest tube and monitor if the air disappears معناتها pneumothorax. إذا الاير still
إذا
there
إيش؟ Again.
if we found مثلا air in the mediastinum and we put chest tube and then the air disappears, this is pneumothorax يعني or regress. طيب بس if it's still there, this is like esophageal perforation until proven otherwise. Is that correct?
طيب. How do you identify esophageal perforation? قلنا in the right clinical context صح؟ واحد is most likely the most common cause is iatrogenic. واحد underwent a procedure وعنده signs. إذا في esophageal perforation it's going there ودخل في fever, it's more likely to be esophageal perforation ما هو pneumothorax صح؟ Then the space أصلاً حتى لو حطيت chest tube is not the treatment أصلاً في esophageal perforation. It's totally different pathology الاثنين. Pneumothorax versus esophageal perforation is totally different لأن الفلويد ولا الاسوفيجيال contact ولا الأشياء اللي جوا it goes between الميدياستنم وبين الاسوفيجيال صح؟ But it causes mediastinitis. Clinical wise في شيء يسمونه الهامن crunch ها؟ It's a sound that it produced during auscultation. Hammond crunch. لكن in the right clinical context يجون esophageal يجون بإدروفاجيا, dysphagia, fever, chest pain with the right clinical context, iatrogenic ولا alcoholic who's been vomiting ولا retching.
So chest tube has no role in
has no role.
What you're talking about actually is bronchotracheal injury.
This is in the trauma case.
In the trauma case, bronchotracheal injury will come with a continuous air leak in the chest tube.
So you apply multiple.
So I mixed up, I think.
But esophageal rupture will not be treated by chest tube. It's surgical.
My question for Dr. Omar. When do I have to consider the spine deformity like kyphosis or scoliosis as red flags? Because some reference consider as red flags, some are not. So can you explain that? And the second question about the role of X-ray in back pain, because some doctors said it's useless, and some doctors we just do it to reassure the patient. Okay.
So we'll start by the first question. The first question is kyphosis and scoliosis is a red flag? So I will say yes or no. And if we're talking about kyphosis scoliosis as a chronic disease, the patient have this deformity in his childhood, it's for sure is not. If he had a deformity which is new and it will not appear, it will look like a kyphosis and scoliosis, which most of the time will mean a chronic problem. So if it's new, I mean there is a new deformity in the back, you can consider this as a red flag. But again, I don't think that you'll have a walking patient or a patient who's talking, walking, alive with a back deformity and he's telling you I have only back pain. For sure he will tell you I have a weakness and I cannot move my limb because he had a deformity. So kyphosis and scoliosis per se, it's not a red flag. But if they have another red flag that we talk about, it's just like any other chronic problem. You don't take it seriously. The other question is, so X-ray. X-ray had actually a bad sensitivity for finding of abnormality in the back, especially if the patient with back pain. The differential diagnosis that we talked about, here aortic dissection, aortic aneurysm, coda equina, it will not be picked up by X-ray like 70% of the time. If you are lucky, you will see the vertebra moved on from the space, compressing a spinal cord. You are very lucky to have this. And in my experience, I saw like 3 coda equina in my life, and CT all of the time was normal, CT and both. So imagine what X-ray will do. So X-ray have very bad sensitivity, and if you are doing X-ray, unless you want to make sure there is no like just tip fracture of the vertebra or small fracture of the vertebra, if you are looking for any serious diagnosis, X-ray is not your investigation of choice, for sure. So no X-ray, if you are investigating back pain and he had a red flag, you can do X-ray just to reassure yourself, but CT and then MRI if the patient still complaining.
سؤال للدكتور عمر. دكتور, would you consider back pain after lifting heavy object red flag?
No, for sure. So let's put it in the context as Mohammed said. If he had a neurological deficit, if he had any other red flag, yes. Lifting of considered as a significant trauma. So lifting an object and then you have back pain, it doesn't consider as significant trauma. So you need to put it in the other context. Post-neurological deficit, retention, and this stuff.
My question is to Dr. Fahad Al-Hajjaj.
رائد ترى والله ما عرفتك الا قبل شوي ترى. الوجه متغير تماما. البركة تخرج.
إن شاء الله الأحسن يعني. So, Dr. Fahad, there's some studies have linked the use of opioids to the regulation of the central regulation of cardiovascular system. So, in terms of long bone fractures, they can bleed a significant amount of blood. Can we use morphine in this case? The second question is the role of benzodiazepine. Morphine and hypotension. There's some studies linked these two together. Can we use morphine in long bone fractures? The second question, the role of benzodiazepine in pain management.
So, بالنسبة للتروما in general ما هو بس long bone fractures. الناس are shying away from morphine nowadays. They are moving to fentanyl والراميفنتانيل والحاجات هذه. المورفين عشان الهيموديناميك انستابيليتي حقته انه يسبب هايبوتنشن ويسبب هيستامين ريليز، الناس قاعد بالنسبة للتروما سبيسيفيكلي قاعد يبعدون عنه. بالنسبه للستيرويدز يوز بالفراكشرز في اورثوبايدز يقولون انها تافكت البون هيلينج. الكلام هذا ثيوريتيكال ما في عليه ستدي لكنه الكلام موجود، يقولون انه تافكت البون هيلينج. واتس اني واي on any occasion يعني you have an alternative. اعطوا باراستامول، ليش تعطيه اصلا ليش تعطينا ستيرويد من الاساس؟ هذا حاجه. السؤال الثاني بالنسبه للبنزودايزابينز. So actually في small confusion انا كنت بحطها قبل بعدين شلتها. So there is pain, there is an anxiety. طيب و these two things are totally independent from each other. طيب في واحد عنده shoulder dislocation ترى يمكن ما هو painful بقد ما هو very anxiety provoking procedure انك تسوي له reduction. طيب بالمقابل البيشنت اللي عنده سيكل سيل ديزيز عنده سيفير بين بس ما عنده انكزايتي. واضحه الفكره بين الثنتين ولا لا؟ اعطيك مثال اوضح. فيه يعني نسبه مجتمع كبيره اذا صار عنده فورن بادي بعينه يصير عنده انكزايتي. من اللي منكم اذا صار عنده فورن بادي ينهبل في عينه؟ كثيره صح؟ طيب is it pain ولا anxiety؟ It's most of the time it's an anxiety, it's not pain. ممكن يكون pain بس it's an anxiety. فإذا patient you need to manage his pain only, benzodiazepine has no role. If you need to manage his anxiety, benzodiazepine is a good choice. طيب أحيانا يكون كل الاثنين موجودات. patient عنده femur fracture يحتاج reduction. طيب يحتاج pain management ويحتاج anxiolytic. فبيحتاج الاثنين مع بعض. في حاجات ثانية غيرهم يمكن يطول الكلام، ممكن تحتاج hypnotic agent، تحتاج البيشنت ينام، ممكن تحتاج amnestic agent. التفاصيل هذه كثيرة ما أتوقع أنها مهمة مرة، بقد مهمة البين لحاله. الباقي هذول الثانيات يمكن أنها تكون procedure oriented أكثر من أنها يعني presentation oriented.
أنا عندي سؤال. إذا كان البيشنت جاي عنده acute complaint and we give them opioids يعني عنده pain and we give them opioids هذا ممكن affect our judgment يصير البيشنت مثلا will affect his alertness يعني and then will affect the يعني the diagnosis وكذا ولا
it affects his awareness ولا it affects management examination.
يعني I want to diagnose the patient so he's in pain now I want to control his pain so I can get more information about his case, right? So if I started by giving him opioids, I think this might affect his يعني his judgment or
يعني قصدك الجudgment حق البيشنت
like I might not get like correct information regarding his case لأنه أنا أعطيته opioids.
ترى ما أسمعك والله.
الحين when you give opioids
ممتاز.
وش يصير بالبيشنت يعني من ناحية المنتل فانكشن ممكن تكون
CNS wise أي ممكن يكون عنده depression.
طيب الحين إذا I want to get like specific information so I can diagnose the patient and act accordingly.
تمام.
إذا أنا أعطيته opioids هذا wouldn't affect my management.
you have to give a very hefty dose عشان المورفين امبير الجادجمنت حق البيشنت وامبير his response. عادة إذا كان عنده pain he has enough stimuli إنه he will be awake. However في بعض الناس يكون very sensitive ل1 agent ياخذ فنتانيل 20 مايكس ويفصل، وهذا موجود يعني بعض البيشنتس يكون very sensitive لحاجه معينه. طيب لكن even though اذا كان البيشنت is in pain غالبا يعني انا اخاف اقول always لكنها قد تكون always البين حقه هذا treatment of pain will not affect the management بالنهايه. طيب appendicitis بيطلع الاكزامينيشن حقها واضح. اذا كان البيشنت عنده فراكشر، الفراكشر دايجنوز باي اكس راي ولا باي الترا ساوند. اذا كان البيشنت عنده abdominal catastrophe بيبقى البين ما هو برايح، حتى لو كان البيشنت intubated he will grimace to touch. طيب unless انه he is totally paralyzed. لكن قضيه انه انا ما راح اعطيه بين مانجمنت عشان البيشنت ممكن ما يقدر يعطيني معلومات واضحه. انا I don't think ما ادري يمكن I don't think انه this entity is clinically relevant.
And I didn't mean this. I mean يعني we can give like IV
Yes.
paracetamol or IV
To
other
answer
than
your question, certain opioids, سواء fentanyl ولا morphine, if you give them in certain doses, patient will go in sedative stage. Yes. So what you need to do is give aliquot. يعني دائما يقولون اللي تعطيه ما تقدر تجيبه بعدين، ما تقدر تسحبه مريض. ف you can give doses, boluses. تعطيني 2 ملغ morphine, you see the response. If he's not responding, تعطيه another 3 ملغ. You can, they call it aliquot. عرفتي؟ If his pain يعني is went away خلاص, this is your target is his pain scores go to من البيج scale حقي. إذا كان 7 goes back to 5 or 4, that means I'm appropriately treating this pain.
Actually, evidence-based never proved that pain medication will reduce the patient ability to give you history or even change your physical exam.
انا totally انا اختلف 100% مع كلام محمد الوادعي، ولا انا مقتنع فيه ولا اعتقد انه صح. ها؟
انت الان you contradict yourself.
اذا كان
قلت لي
في
20
اذا
mics
عطيته
of fentanyl
انا ما
could
اتوقع انه
cause
في
him-
بيشنت تعطيله 2 ملغ وبينفع اصلا. 2 ملغ خلها لك، الا اذا كان البيشنت عمره 99 زين والبيشنت اصلا هو از اوريدي
الحكم بيننا.
هيز نوت ليفت.
Doctor, there is
ولا
no black
وزنه
and
10
white
كيلو.
in medicine. يعني I think it's a safer approach to go like 2
ها؟
milligram. I think it's
ما اتوقع انه سيفر ابروتش. انا عندي تيوب وعندي لارنجوسكوب. I can intubate the patient if he's a respiratory arrest.
I want to avoid the need to intubate him.
ما-
That's
أنا-
why
I
I'm
don't
giving
want to-
aliquot of
I don't
pain
want to
medication.
avoid
So let's
intubation.
close this and
طيب
As Fahad said-
I'm going to act as the middleman.
Hey.
No, I think Fahad has valid points in terms of appropriately dosing analgesics is a crucial and a cornerstone concept in pain management. There's no question about it. And at the same time, I also agree with Muhammad that there are specific instances where